Good morning. Thank you, Leon. I'm an associate professor, actually just promoted to full professor, but
Hey,
shortly it'll be announced at the University of New Mexico Health Sciences Center. I work in the Center for Global Health and the Division of Translational Informatics within internal medicine here. And I've been spending a number of years working with very large scale electronic health records and administrative claims data. And today I'd like to talk a little bit about the work that we recently published on drug-dependent risk of self-harm in patients with bipolar disorder. And it's a comparative effectiveness study where the outcomes themselves are a combination of what is coded in the data as well as what is imputed using machine learning. And so with that, I do not have any personal financial interests in the presented work, and it was funded by the Patient-Centered Outcomes Research Institute. So here's the paper. It it just came out recently in JAMR Mental Health, and our objective was twofold. One is to apply machine learning algorithms at the level of a visit to impute uncoded self-harm in administrative claims data for individuals with major mental illness. And then in the subset of patients who have bipolar disorder, we wanted to compare all commonly used pharmacotherapies for risk of self-harm. And so just by way of background, of course, it's in the news, it's in our minds also with COVID and so forth. We know that suicidality, including both attempts as well as completed suicides, and then there's this broader umbrella of self-harming behaviors, of which attempted and completing suicides are a subset. It's a big deal. Suicide is a leading cause of death. Especially we see it in major mental illness, which is bipolar disorder, schizophrenia, schizoaffective disorder, and major depressive disorder. And there's a fair literature showing that incomplete recording and coding of various thoughts, actions, etc., related to self-harm. It's a real challenge in that if you're going to study these outcomes, but they're not recorded properly in the data, how are you going to answer key questions about the incidence levels of these events, about the effectiveness or lack thereof for various treatments? And so I think I spoke about this at the same group, a prior work of ours. It was this paper in JAMIA back in 2020, where we talked all about just the process of imputing self-harm that was probable but not actually coded in the medical records. And so we're going to build on this paper and then try to compare the common treatments for bipolar disorder, both the coded and imputed. So how to think about the study is you have some period of time of observing a patient. And so we make sure we had at least a year so we could look at what drugs they had taken, what comorbidities were present. And then they are coming in for a inpatient or ER visit and are discharged and have some treatments. And what we see, which is extremely common in bipolar disorder, mental illness in general, is someone may be 30 days on one drug and then shift to another, possibly go off a drug, shift to a second drug, be on a combination of a polypharmacy regimen. And this is basically very typical. The first treatment is often may have side effects, there may be adherence problems. And so when you look at the record of what drugs are actually filled in administrative claims records, it's a patchwork. So typical designs that involve an intent to treat model where you start with a drug and assume they keep taking it is just invalid in mental health. And so we've kind of diagrammed the study, which is you basically want to model the time to an outcome as a function of a time varying treatment of being on or potentially off different regimens, also with fixed covariates representing potential comorbidities that could bias what the selection of drug is, and look at the time to self-harm. And there's, of course, right censoring, which is either the end of the data or because our claims data doesn't cover the drugs that happen during hospitalization, we also will stop the clock and right censor when there is any kind of hospitalization. So the question is, how do you assess the risk of self-harm if it's underrecorded? So a hospitalization that occurs where somebody presumably hurt themselves is what we're trying to determine with machine learning, as well as combine that with when it actually is coded that somebody came into the hospital or the ER for self-harm. So I guess I'm repeating myself, but a lot of the machine learning techniques and the ways that we verified that we're not overfitting, the ways that we verified with a gold standard and so forth, that we indeed are detecting unrecorded self-harm is sort of the subject of a whole other talk. And so sort of have to take that as a bit of a black box. I'll expand on it a little bit and look at this prior work. But just by way of review, and I'll talk a bit about some of the differences between how we did our machine learning in this work versus the prior work, is we started again with IBM Market Scan, commercial claims and encounters, but we also added Medicare. So if you're familiar with these databases, there's commercially insured people, and then there's Medicare. And it turns out the patient IDs can be linked together so you can track people both prior to them entering Medicare and over the course of Medicare. And this enables us to get a span of ages from childhood all the way up to retirement and beyond with these two databases. The data is transformed into the OMOP Common Data Model, and we looked at the period from 2003 to 2016. We had 11 million individuals who had at least 2 diagnostic codes for major mental illness. And so we then look not at an individual level, but at the level of what we're calling a meta visit, which is we snap together adjacent inpatient, emergency, and outpatient visits that all could happen back to back. Because what can often happen is someone comes in to the ER, they're patched up for the damaging behavior that they engaged in. They may be transferred to the inpatient unit, and if they had something severe, and they may also have an outpatient follow-up immediately thereafter. We looked at only meta visits that had an inpatient ER component, and the reason is first of all, there were so many outpatient visits. There was like 26 million inpatient or ER meta visits versus 635 million pure, minus 26 million pure outpatient visits. And we saw there's about 1 in 100,000 outpatient visits had coded self-harm. So it was so infrequent to have it coded as part of an outpatient visit that we basically did not include those in our study. I think it did actually represent about 6% of all coded visits though. So the unit that we're using for machine learning is this visit. We're characterizing what happened during that visit based on billing codes. There's tons of ICD-10 billing codes related to self-harm, includes different ways, all kinds of poisonings, and there's gunshot wounds and many different forms of self-harm. ICD-9 has sort of a smaller set of them, and in this observation window spans both ICD-9 and 10. We found the mappings of these codes to SNOMED in OMOP weren't so good, so we had to actually enumerate every single ICD-9 and 10 billing code, work with those as the outcomes, and then the covariates that would characterize one of these meta visits We looked at any drugs that were filled. We looked at all diagnoses that were not related to self-harm. We mapped them to SNOMED to harmonize ICD-9 and 10 to a common vocabulary. Procedures were a real pain because there's four different procedure vocabularies used in US healthcare, CPT-4 and HCPCS, which are kind of the same thing, but there's sort of a subset of codes that are related. And then there's ICD-9 and 10 procedure codes. Those are typically used in hospitalization environments. CPT-4 is typically used in specialty clinics, both inpatient and outpatient. And so then we mapped all these to, so we mapped all the procedure codes to ICD-10, which is a one-to-many mapping, which is kind of messy, but it was our way of harmonizing them. And then when we mapped to SNOMED, we also got all ancestors of SNOMED codes. So there's a lot that goes into this. We also put the age at the meta visit, the sex, the year of meta visit, and there's this thing, a code position that says, essentially the more complex the visit, the more billing code positions are used in the record. So if you're using the 15th slot, probably there was a whole lot of treatment going on versus something that just used the primary or secondary. So we used all the stuff in this prior JAMIA publication really determined the ML approach, where we had tried different machine learning methods, settling on XGBoost. We did multiple approaches to ensure overfitting not occurring. We did a verification through multiple clinicians assessing the machine learning classification. And so using that, we then said, okay, let's use this technique on this set of data that includes all the meta visits from market scan, both commercially insured and Medicare. We use the same parameters as from the JAMA publication, and we use fivefold cross-validation to basically create a prediction or a classification probability for each meta visit. And so what's different is we were able to cover a broader age range, and we excluded some hand curated covariates that we used in the paper, the earlier paper. So what's this look like? So we had 11 million people, and those 26 million meta visits were used. Basically, it gives us a lot more observation of self-harm. And then we took the 564,000 people out of these that had bipolar disorder diagnoses, and we used those meta visit probabilities. Turns out there was 8,813 either coded or imputed with probability above 0.5. And then there was, among the censored patients, so these are people who either had a self-harm unrelated hospitalization, or that there was other censoring, typically the data ending, there was 334,000. So rather a small number of events, and this is even with imputing. Turns out there's just a very small number of coded self-harm visits, something in the neighborhood of several hundred. And so this machine learning probabilities of self-harm for that terminal visit, if you recall that diagram, is what we use as the outcome. So this is a histogram of those probabilities across all the meta visits for those who had bipolar disorder. So here were the coded cases, and you can see the probabilities are skewed way to a high probability. You see the meta visits for which there was not any coded self-harm, but there's this big fat tail out here of high risk of self-harm among the so-called controls. And so what we did is we as a sensitivity analysis, we picked thresholds of confidence from 20% all the way up to 95% to basically impute the risk of self-harm, because we're it's unclear what is the most appropriate threshold. And then we actually had the coded self-harm itself as the probability 1 in our sensitivity analysis. The main analysis used a 50% cutoff. So how did we do comparative effectiveness amongst all these drugs? So we used a time-varying Cox regression for risk of self-harm. So you had fixed covariates, which are the comorbidities in the 12 months prior to treatment, and sex, and then we fit age as a spline. And then time-varying covariates are the treatment that varies over time, as well as the number of prior different unique drugs tried. And I'll talk more about that in a moment. And then there is a mutually exclusive and collectively exhaustive set of 64 different treatments plus no drug compared to lithium. And then again, the outcomes in coded or imputed self-harm, greater than 50% confident. And then we ran the sensitivity analysis, as I mentioned earlier. So we also ran a secondary model that lumped all of the drugs together into basically pharmacotherapy versus not, and with and without psychotherapy. So here's what the Cox regression model looks like. It turns out age is quite a nonlinear relationship. There's a high risk of self-harm during adolescence that then drops off and basically continues to drop off until you leave this earth. And the number of drugs tried, so this would be the number of unique agents, so like lithium and lamotrigine and so forth. Each one that you tried in the 12 months prior and then ongoing as you switch up drugs. It was an attempt at modeling, essentially, you'd expect that someone who would fail more and more drugs might have a more treatment-resistant case of bipolar. Interestingly, as we modeled this, here was 0 prior drugs. So this was your first treatment. You actually, as you tried the next and next and next, sort of second, third, fourth, fifth line treatment, there actually was a little better outcomes. So often that very first treatment's not successful, or perhaps hard to say what goes on there. Then eventually we have much fewer people who had tried this many different drugs, but it starts to slope upwards, but the confidence intervals are very wide. But this sort of gives us an indication of like how much indication bias there might be as a function, and how might it drive the risk of self-harm. And at least going up to about 7 or 8 different prior drugs, it was not statistically different from 0. In fact, actually trying the first, second, third, and fourth was a little bit below 1. So there's these dotted blue lines with the 95% confidence intervals. And so the reference is basically no drugs, and then you can look at a hazard ratio versus not having, versus how many additional drugs you've tried. So here's sort of the big summary of the risk of self-harm, looking at the drugs for which we used the coded plus imputed at 50%, where that confidence interval fell either below 1 or above 1. And then the purple bars show the ones that were more lax, so you allowed an even more lax stringent of self-harm imputation. And the green ones were tighter and tighter stringency, all the way to the darkest green line on the far right was coded self-harm. Now you see sometimes coded self-harm could not be included in the model because there just were not any events or enough events to put it in that given Cox model. And so this really illustrates why we're doing this, which is when we use just the coded self-harm, the confidence intervals are so wide, or there's no events, and we can't even get a good estimate. However, we look over a rather broad range of uncertainty for the imputation of self-harm. We get a fairly consistent results, showing, for instance, these two categories of antidepressants, NDRIs plus SSRIs as a combination therapy, or NDRIs alone or SSRIs alone, all have a lower risk of self-harm than the reference of lithium. And so lithium would have a hazard ratio of 1, lithium monotherapy. And so you see several other drugs here like risperidone, aripiprazole, valproate, lamotrigine, so different monotherapies. By the way, valproate, lamotrigine, those are mood stabilizing anticonvulsants. Risperidone and aripiprazole are second generation antipsychotics. Some of the drug regimens that had riskier or worse outcomes, and we can't impute causality, there could be unmeasured biases and so forth, but a first generation antipsychotic, various combinations with second generation antipsychotics, and you could be concerned, perhaps this could be an indication bias. However, where people with psychosis would be likely to be taking antipsychotics, potentially have a worse case of bipolar disorder. That could be the case, although we did, try to control for that. So this is kind of the, the summary of this is the summary of the most significant findings. We actually had more than 65, more than just these drugs were examined, but the others were not statistically significantly different from one. This is the secondary model where we lumped all pharmacotherapies together. And so we modeled as a time-varying covariate. The reference was no drug and no psychotherapy. So that would be at a hazard ratio of 1. Interestingly, this is no drug plus psychotherapy has the lowest risk. Drug plus psychotherapy had a higher risk, and drug alone had the highest risk. Now, the challenge with looking at this, of course, is people who are on no drug might be stable. They might have a less severe or be in remission. And so these, we don't want to walk away and say, just psychotherapy alone is the answer for dealing with bipolar disorder. But we could at least entertain the hypothesis that psychotherapy is an important adjunct to drug, and drug alone without psychotherapy might be something you want to be concerned about. So this also shows the pre-treatment covariates in terms of how statistically significantly protective or risky they are. And so you see, for instance, if you had prior coded self-harm, we had to create a very special axis over here, where even with just the coded self-harm, you had something like a 37-fold higher risk of subsequent self-harm if you had prior coded self-harm. And also imputed self-harm had a increasingly higher risk. So there's a number of factors here like substance abuse or dependence having a consistently higher risk. Let's see what else. Prior hospitalization. So there's a lot of things that go into this, and I'd encourage you to look at the full paper. But interestingly, there's also some things like, why would folks who had cancer potentially have a lower risk of self-harm, at least imputed? The error bars cross 1 for the purely coded self-harm. So in summary, We saw a risk of self-harm varying more than 8-fold among different bipolar regimens. An exposure to antidepressant or mood stabilizing anticonvulsant monotherapy was associated with a significantly lower risk of subsequent self-harm compared with lithium. And remember, we're using lithium as a reference. Lithium itself has a large literature suggesting it's protective for self-harm. So when we're showing, things above or below lithium, it's not to say that those drugs are risky for self-harm. It's just saying that relative to lithium, they're more or less significantly protective. And there could be good reasons why you might be on a different therapy than lithium. Psychotherapy was perhaps one of the strongest signals, strongly associated with decreased risk of self-harm. And then, this story of using an imputed phenotype, enabling us to enhance the power to look at many more therapies than what we could with purely examining the coded outcomes. Of course, we saw this pattern that's sort of well known that adolescence is a peak risk period, but I think that graph with regard to age shows it quite starkly. And of course, our data support the evidence that prior self-harm is one of the strongest predictors of future self-harm. So with that, I'd like to acknowledge our many collaborators at the University of New Mexico and folks from many other institutions. And especially I'd like to acknowledge Dr. Nat Hurwitz, who taught me so much about bipolar disorder and psychiatry, who passed away during the preparation of all of this work. He was so excited about this work that we were able to study all of these treatments, and this was really special for us to be able to honor him as a co-author in this work, because he so much drove the design and creative endeavor behind this. So with that, I'd like to turn it back to Leon to moderate any further discussion. So thank you.
Thanks, Christoph. That was so interesting. Congrats on completing this terrific bit of work. There's some methodological questions that I have that may be a little too persnickety. So I'm wondering if let's ask folks in the group may have first, and I will jump on if there's room at the end. See, Jesse just came off mute, so I expect a great question from her.
I did not. All I did was put up the clapping.
Oh, gotcha.
Thank you, Christoph. That was very cool. I don't have, excuse me, I can't talk. I'm going to go off on mute.
Yeah, let's give other folks a minute to see if they can raise their hand or ask something.
And I'd also like to acknowledge Nick Love, Praveen Kumar. My graduate students are actually on this call today. I invited them to join, so they did a lot of the legwork behind this, and it was a great team effort.
Great job, guys. So let me start the ball rolling. And so one of your early steps, hearing some echo, sorry. You guys converted the IBM market scan data and the Medicare data into OMOP. Can you talk a little bit about the rationale and also how difficult that was? What was that process like, and why did you feel that was the right common denominator of clinical data model to use?
So there is a tool that we used that folks, I believe, from Janssen created. It's not well documented, and it's took us some months to actually get it to work for these databases. And when it was done, there was the 2016 version of the OMOP vocabularies or something like that. And so the mappings, as an example, there's mappings to like bipolar 2, for instance, in ICD-9 gets lumped into, there's not actually a bipolar 2. It gets lumped into a, I forget the exact code, but most of your bipolar 2 is going to be there. And OMOP will map that to some parent term called just bipolar, right? And so if you're interested in that predominantly depressive phase bipolar and you're trying to model that, it's going to be lost. So there's some issues with that. One of the so the mapping process is basically, it takes all your source billing codes from ICD-9 and 10 and maps them to a SNOMED equivalent. Now that choice of what that equivalent is it's done by experts, but there's literally thousands of billing codes, and all of those decisions, when you get into a very specific domain and you really know what you're doing and you look at those mappings, there are numerous things. For instance, intentional self-harm by hanging, right? There is not an equivalent SNOMED code for intentional self-harm by hanging. Back in 2016, they might have coded it as asphyxiation and not put intent, because there is an asphyxiation. They might put hanging. Now in the current, I think it might map to 3 or 4 different things. So there's this, intentional self-harm, or intentional suicide, or intentional attempt at suicide, asphyxiation, and then hanging, right? But hanging without actually saying what the intent is. So there are, and there's a lot of poisonings, for instance, that are marked either intentional or not in ICD-9 and 10 that don't have direct intentional mappings. So if you're trying to say this was intentional poisoning by barbiturates, and there happens to not be a SNOMED code for that, it would sort of fork into poisoning and intentional. But many times back in 2016, a lot of those intentional mappings were not there, and so you just have this poisoning by barbiturate. So when we did this work, we had to basically catalog every single one of those and not count on a SNOMED mapping. Ideally, with OMOP, you might want to say, yeah, let's just take every descendant of intentional self-harm within the SNOMED hierarchy, use that as an outcome, and call it good. And so what's the benefit of all of these mappings, however, has been in the harmonization, when you can do your covariates. That being said, so we're rolling up things like, suppose we had a code for cardiovascular disorder, all descendants of cardiovascular disorders in SNOMED, which could be thousands of codes. We can kind of roll them all up and then say, was or was there not cardiovascular disorder present within our model? And you can kind of not have to curate thousands of codes, and you're counting on their expertise. However, that being said, the same question marks about, what choices of what got lumped into the mappings to different cardiovascular disorders might be questionable. So these are the warts and the things that, as you get deep into OMOP, you have to be concerned about. And what I would say is the most powerful and useful part of OMOP, frankly, is the way that they have very clean mappings of all of the NDC drug codes, which include like the brand and the manufacturer and the dosage, directly to RX norm, basically dosage and delivery mechanism and so forth. So for me, the most power I get from OMOP is that. Sometimes using it to roll up vocabulary terms where I just don't have the bandwidth to enumerate thousands of codes, and I'm gonna use kind of the canned ones. But as well as sort of the simplicity of, you can have a big database that's got many, many tables, like the market scan data has kind of a mixture of different record formats for the inpatient and the outpatient and the facilities claims, and they can map them all into, you know, a smaller set of tables that you can work with. So as always with an abstraction, there can be loss of fidelity of information. And so I kind of, you know, over the years, I appreciate the value of OMOP. At the same time, you almost have to know your source data and OMOP, and it adds a layer of complexity that's sometimes can cause you more grief than if you just work with your source data. So long answer to a question, but these are some of the things you have to know about when you're working with these data models.
It's actually super helpful. I appreciate you walking us through your thinking process. There's some work that I'm seeing, actually first came out in 2015, on trying to do machine learning directly on fire without any pre-processing, right? There was an original paper from Google that attempted it. And I'm seeing some commercial offerings that claim to be able to do it. I'm not suggesting that's an option for the kind of work that you did, but that's what was in the back of my mind when I was thinking about the OMOP conversion. The other is, I suppose there's a very naive model that I had in mind that would not have the power of what you did, because you wouldn't have the ability to analyze the covariates, but of, you know, developing computable phenotype from the raw codes that would just give you the probability that self-harm occurred, and using that as the outcome measure, right? Without actually doing all the recoding of diagnoses. So, but I see that, of course, I wouldn't get you to what you got, because you got much more interesting and rich results, but that's probably what I was thinking about when I was thinking about the OMOP conversion. So let me ask a substantive question. There's the finding with the number of drugs. I agree, it's really intriguing, right? Like, you know, the question is what's, you know, and I would say that, you know, without knowing, being a psychiatrist or really knowing the domain, intuitively it seems to make sense that the probability of self-harm would decrease with some number of treatments, because it's showing persistence, right? Since we know that the typical path is, the typical outcome for an average patient is that you're going to switch from the first line of treatment that you're on.
Yeah, like some trial and error, almost invariably. Yeah.
It's strongly correlated with just continuing with any sort of treatment program, right? So I'm wondering if there's a way to distinguish that from actually number of drugs, right? If you actually look at the duration of treatment as a separate variable, right? And you try to, I mean, they're going to be very closely correlated, but there may be a way to tease out the variances that are due to just persistence versus trying new drugs.
I think that it's sometimes challenging to conceptualize the time varying Cox model, in that, you know, we have to move to these more and more powerful analytical techniques, and so the case can be made, it itself does cover time of treatment, because it's a survival analysis that's timed to an event. And yet, you know, to the point about, like, there's this whole history of a patient, right? Not just the 12 months that we used as a sort of a reference for saying about all comorbidities, but there's all the time prior to seeing them in this database as well, you know, childhood stuff that we don't see and so forth. So the whole trajectory of sort of a lifetime of symptomatology, of treatments, and so forth, to be able to model that granularity and think about kind of some abstraction of what state somebody went through to get to where they are now, that now you're starting on a treatment, and then that induces a change potentially, and you've now moved to another regimen. You know, it starts to get to a complexity that we will not have the sample size to consider all the possible states and so forth. At the same time, you sort of investigate, well, what are the potential largest biases? How much do our models change when we look at those different potential confounding factors? Are they largely stable anyhow? So have we done a good enough job? We'll never reach the level of the randomization of a randomized controlled trial. On the other hand, randomized controlled trials are not going to be done on, hey, let's keep switching treatments and do trial and error. I mean, that's actually the reality, what happens in the real world. So we're trying to say, well, what can we do to generate something in the total evidence vacuum of, like, we're looking at 4-drug polypharmacies, actually. And so we had to compress that into, like, well, let's do it as classes because there's not enough sample size to look at this exact antidepressant and this exact mood stabilizing anticonvulsant and this exact antipsychotic. So we collapse into classes for our polypharmacies, for instance. But it may well be that there's some very good 3-drug polypharmacies, but on average, 3-drug polypharmacies are maybe not so good. So that could be hiding in there. So it's the potential for larger and larger data, the ability to maybe do some network studies through the Odyssey Common Data Model to look at not just 1 or 2 databases, but many. Doing different analytical methods. I mean, like this particular Cox regression model is a lot of people will do propensity scoring based models. We couldn't really do that with a time varying shift of treatments, right? A propensity score basically says let's do a model to predict the chance that you have this drug versus that drug as a decision that the doctor uses based on your past history, and then try to either match or adjust for that potential bias by either grouping, selecting a subset of people who are well matched or something, and do that. When you're dealing with this time shifting polypharmacy, we don't really have good methods for it, or at least ones that we've been able to find to do this. But that's kind of the direction to go, that we'd like to go in terms of methodology. The challenge starts to be, how do you explain this stuff where it becomes mounting complexity of multi-state survival analysis models that there's, a few hundred people in the world who are experts in, and I'm not one of them, so.
Thank you. Great discussion. Want to make sure that others had a chance, want to ask a question, can, before we stop recording.
I had a question. I first of all wanted to say that it was a really nice talk and a very beautiful study also. I was wondering if you had a chance at all to check the machine learned predictions. So you had, of course, the coded self-harm instances, and then you had a whole lot of instances or patients that were labeled, or visits that were labeled as self-harm without there having been a code. Did you have access to, for example, notes or anything else where you could do a manual analysis of whether there was evidence of self-harm that wasn't coded? Because as you explained, there's sometimes difficulty in just coding self-harm.
Right. So great question. So in our earlier JAMIA paper, we had, of course, this was claims data, so we didn't have notes. We had clinicians, nevertheless. They had the benefit of looking at the history of all the billing codes and making their best judgment of whether this was self-harm. So somebody who had, they were getting their wrists sutured, and they had bipolar disorder, and they had thoughts of self-harm recorded, but intentional self-harm was not recorded. And someone said, yeah, I think more than 50% chance. And we had three clinicians each do that, and we looked at the comparison of what the machine learning said for those and what the human said. And so precisely for this group of people who are not coded, so we looked in that subset, more than 50% of the ones that our model said, yeah, this is probable, the clinicians also said it was probable. And we saw 19-fold more of those than were coded. So in this new JAMR paper, we referred to a British publication that did look at this issue of undercoding. And when we looked at their rates among hospitalizations with folks with bipolar disorder, turns out our level of imputation was actually a little bit lower than what they saw when they had carefully looked at that. That all being said, we're funded for a new project that's been taking this forward, and we've been working in the VA data where we do have the patient notes. And so we've been actually going and looking at the people who didn't have self-harm coded but the model said high probability, and have done some chart review and have found a very high concordance at the highest level of probability, and then as the probability drops, you see a lower concordance. And although we do see one troubling thing that points to remember I showed this something like 40, 50-fold higher risk of subsequent coded self-harm based on prior coded self-harm. There's a pattern in the VA data, and it may well be in general, that when you have intentionally hurt yourself once and they code it, the follow-up visits, they're not necessarily coded with sequelae of self-harm or a check-in visit for self-harm. They're actually coded with another self-harm. So it'll say they poisoned themselves again. They poisoned themselves again. No, they were following up to see, is this person still at risk? And so the time to event thing is skewed by this sloppy coding, or someone say, yeah, I visited them for this self-harm, but no, they didn't actually do it again. And so this points to, I think, an important need that we have to go into the notes themselves. We're going to have, because it's not scalable, we're going to have to, do natural language processing and stuff on the notes. So we've started adding that to the machine learning. We've seen that the NLP does increase the prediction performance when we've checked again, looked at the area under the curve and so forth. And so my takeaway after working with the VA data is that we're going to need to be using the notes more and more for any kind of mental health condition. And there's interesting stuff too, like people are regularly asked, have you ever tried to harm yourself or kill yourself? And they use that to assess, should they be put as part of their risk estimate to decide, should they be put on a high risk list, right? Should we monitor and follow them up? If you look over time, if you look at the entire history of the notes and you do a chart review, you'll see 10 years earlier, they actually really did try to kill themselves or harm themselves. And they'll say yes sometimes, and they'll say no sometimes to that, and they'll say, and it'll alternate over time. So there's this phenomena of what a person is saying, maybe just to get people, I know if I say yes, I ever did it, it's going to open up a whole line of questioning, and I don't want to deal with that, might be the reason. Then maybe they forgot. It may be, they don't want to disclose that to this particular clinician, even though they disclose. So there's this, whether someone, and they're doing this with also, do you have such thoughts right now? And they came in for it, and they say no. And so there's depending on what's self-reported, is actually, for historical veracities, is also one of those real fuzzy spots in the data. All that being said, we have to not make the perfect the enemy of the good. We can learn from this data despite it being noisy. We can do a sensitivity analysis and show, hey, if it's stable, regardless of the noise. And also remember, we're doing a hazard ratio. And so when we're taking a ratio of risks between one thing and another, if we can assume the level of missingness or undercoding might be kind of the same between the two groups, or at least it's not too bad of an assumption. I think this is why there's a stability of these risk estimates that we can get even when we might be on average missing 50% or 90% of whatever question it is we're trying to answer. So I think it's really important when we try to say, here's the absolute risk of something, we're probably going to get into more trouble than if we try to do a relative risk. Leon, you're muted.
Thank you. Our great enemy, the mute button, has defeated me yet again. I just want to thank Christoph once more. I think it was a terrific job. Great questions, everybody, and great answers. So I'm going to stop recording, and we could use the last 4 minutes for the logistics portion of our call. So I'm going to